Well, I can tell from the clinic that most of the patients, they are immediately restrict their diet, and the most of often that they are restrict is fiber. We know that fiber is associated with beneficial microbiota composition and metabolites, and for sure we want that the patient will consume fiber. But also in active disease, we can adjust the specific fiber in certain patients that have a stricter. Of course, we are advised to give a low fiber diet, but beside this, we want to promote.
I think fiber is a good thing to talk about because it's very complex, and I think before people get IBD, high fiber is probably good, and it's probably good across society. And we do see a reduction in fiber in people who are subsequently at risk of IBD. And then we use low fiber strategies to treat Crohn's disease in particular with diet. But then as we roll into a maintenance phase and people are well, then probably fiber should be a part of their diet again. So I think it shows that one example, that one foodstuff across those three different positions shows how complex it can be trying to understand the interplay with diet and IBD in those sort of three phases. So they're all quite different, and they do vary a little bit depending on which particular food stuff we're thinking about. So we've just published a paper in Gastroenterology that pulled over 1,000 new onset IBD patients' microbiomes together to try and understand what the signals are that are there. People have talked about reduced bacterial diversity for quite a long time, and that certainly is a facet. It probably does matter what sample type you're looking at, whether you're looking at biopsies or stool samples. It probably matters who you're comparing them against. So you'll see more convincing signal against symptomatic controls than healthy controls. We also showed that you have a different ecosystem between feces and biopsies, particularly in Crohn's disease and controls, but less so in ulcerative colitis.
For me, what is really interesting that we can see that the pathway, the microbiota metabolite pathway is different from IBD patient versus healthy population. We can see that the metabolites are more utilized in IBD patient, fat and protein, and less carbohydrate.
I actually think Crohn's is probably the first disease of the microbiome that affects the human, and I genuinely believe that the answer to Crohn's is a microbial one, and I'd use exclusive enteral nutrition as the kind of evidence for that. I think if we understood how that worked and we could replicate that in other ways, then we might be able to look at longer term remission without some of the drug therapies that we currently use. And I think ulcerative colitis is a bit trickier. And I don't know that there are as strong microbial signals there. There's a bit of signal from fecal transplant, for instance, that might work and is up to about 30% of patients with ulcerative colitis, but it doesn't necessarily seem to be sustained. I think we need more in that area to try and understand that better.
Well, I think that both Crohn and ulcerative colitis, the microbiota has an important role. As I can see it also in ulcerative colitis, we are targeting the microbiota. We know that FMT is more effective in UC than in Crohn disease. We know that probiotica is more effective in UC than in Crohn disease. We know that and we also know that we have emerging data regarding diet. Of course, it's less effective than Crohn disease, but we are targeting through this strategies the microbiota. As you can see it, both the Crohn disease and ulcerative colitis, we have trigger interaction between the host, that is the barrier function and the immune system, and we have the microbiota, and we have, of course, the diet and the environment factor, and of course the diet is the major factor, and each factor interact each other, and each one is really, really important in this triangle.
So there's probably more of them for Crohn's disease, and I suppose this would point towards eco consensus and diet and nutrition. So things like healthy diet, increasing fruit, vegetables, nuts, seeds, legumes, reducing sugar drinks, perhaps. We're debating this quite a lot, so it's a big theme of our meeting today, ultra-processed food, which does seem to have a signal in Crohn's disease, but that's such a broad category, it's hard to know what that means. And it's such a common part of Western living that it's quite hard to say to people to remove that. Certainly thinking about perhaps reducing ultra-processed food intake. Fiber seems to be important, particularly in Crohn's disease. So increasing fiber in the diet. There are some other more specific recommendations about vitamin D and zinc and fat types and things, but it's probably getting into relatively small print. And I think what we need to be able to give people advice that they're actually able to pick up and follow. So I suppose healthy diet, high fiber, avoiding ultra-processed food where possible would be 3 key messages. What do you think?
Okay, I think that first we need to understand what is studies, what is the research in prevention. We're talking about, for example, intake, we're talking about consumption, we're talking about the highest intake versus the lowest intake. And this is really, really important point because we can see that, and for me, the most important thing right now, it's ultra-processed food. We know that it's in debate, but we can see, according to the recent published article in Lancet, that ultra-processed food was associated with different type of diseases, and the most associated was in Crohn disease. So, and I'm not talking about avoid ultra-processed food, I'm talking about the wider population, just to reduce, because the intake of ultra-processed food is very, very high. It's almost 60% of the daily requirement, daily intake. So it's not just avoiding, it's just reducing. And it's really about talking about education, diet quality. It's lower ultra-processed food and more healthy eating patterns. And this is in parallel to the healthy eating patterns. We are talking about more Mediterranean pattern that we know that is very healthy in a lot of aspects.
Question. I mean, I've kind of been in this field since 2009-ish, so probably 15, 16 years in. We started off probably believing that probiotics and things would come along and transform IBD, and they didn't. And I think some of that is because the ones that were used were chosen for convenience purposes. I think we've come through a phase where we had quite a lot of interest in microbial therapies. So I think there will be, in 10 years, there'll be more research on diet and IBD, there'll be more research on FMT and UC, there'll be potentially some more kind of targeted microbial therapeutics, live biotherapeutics that are targeting that space. But I think that will all go in parallel with more developments in drug therapy and new immunosuppressive agents. And I suspect the future will be a patchwork of the two, where we're trying to gain maximum efficacy by combining things. And so there's a lot of hope now that we can get a cumulative effect by combining therapies like that.
Microbiota is a very interesting topic, but we also understand that the more we know, that we understand that the less we know actually, and there is a lot of unknown, and it's very, very complex. So today, if the patient comes with his microbiota profile, there is nothing I can do with it. So in the future, I hope that there is something that I can do with it. First of all, that I will understand more, because there is the developing research about it. And maybe I will be able to, according to the microbiota, it can serve as a biomarker to respond to certain dietary aspects, approaches. Then I will know what is the best fit for the patient.